Hey, everybody, welcome back to Healthy, Wealthy, and Smart. I am your host, Karen Litzy, owner of Karen Litzy Physical Therapy, located in New York City. And today we are going to be talking about the social and political drivers of pandemics, from the plague to COVID-19, of public health. And so I'm really, really excited to have on the show this week Dr. Tyler Evans. He is an experienced and passionate infectious diseases and public health expert who has been on the front lines of major disease outbreaks around the globe. He is also the CEO and co founder of Wellness and Equity Alliance, a national alliance of public health clinicians and supporting operations committed to transforming healthcare delivery to vulnerable communities. His latest book, Pandemics, Poverty, and Politics Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19, is available now. Dr. Evans, welcome to the podcast.
Thank you. Great to be here, Karen.
I'm so happy to have you here. Now, before we get into the bulk of our conversation, can you tell the listeners a little bit more about your background and what led you to infectious disease and to working with these more vulnerable populations?
Sure, happy to. So it really, I guess my life can be organized into a few different chapters. Let's put it into 3 to 4 chapters. The first chapter was my youth, which was shaped by a number of different factors, mostly by the sort of the untimely loss of my family. I lost my family between my father to my mother to my grandparents. Sort of lost everybody by the age of 21, and so that was naturally traumatic. All a series of different sort of traumatic events, not one sort of event. And so, but that was naturally traumatic, which left me on my own for the most part, right? So I had to figure it out, at a very young age, and so that in conjunction with other sort of adverse challenges in my childhood, my mom drinking a fair bit, so chronic alcoholism, as well as some depression and other elements, really allowed me to sort of understand what sort of adversity feels like, what sort of calamitous conditions sort of feel like. And so when I kind of put those all together, in addition to having two daughters at a relatively young age, by the age of 24 for both of them, I had some real life experience. And so I was able to get into to a pretty prestigious university. Just the stars aligned that way. Sometimes I don't really know how that happened. I actually got a GED. And so I worked my tail off to get into University of Southern California. And so that was sort of a success story for me. And then just always sort of knew that education was going to be sort of the path to success for me. So I stuck to that, and during my college years, my undergrad years, I started spending time in places like Mexico, Tijuana on the southern border, and that sort of that profound disparity between the United States and Mexico, in that sort of area was very much an eye opener for me. So that sort of laid the groundwork for my sort of future state, my future me. And so that was sort of the first path. The second phase started off with my graduate studies, where I started spending a lot of time in Africa. So this is still in the late 90s, early 2000s, when I was spending time in places like Uganda and South Africa. And at the time, there was a sort of big international spotlight on HIV and AIDS. And organizations like MSF, Medicine Sans Frontières, Doctors Without Borders, started becoming increasingly more sort of well known. They ended up getting a Nobel Peace Prize, and we're working on an essential access campaign. So I got out there as a grad student, just doing some sort of summer internships and whatnot, and was just fortunate enough to kind of get into these experiences where it was just profound eye openers. And I ended up seeing a bunch of folks that were HIV infected and did not have access to the medications, unfortunately. So these sort of these coexisting sort of reality between the sort of the global north and the global south, having all these medications, because back in the 90s and early 2000s, that's when the medications really started to sort of accelerate in terms of technological development. The problem was it was completely out of the hands of the majority of the folks that were infected with it or were at risk of getting infected. And so literally like almost 80% of folks could not access the medications. So working with organizations again like Doctors Without Borders and the UN agencies and whatnot, I started to kind of see how the collective voice of physicians and healthcare professionals could actually make a difference in people's lives. So that for me was a turning point. That was a big sort of light bulb moment for me. And I had been traveling since I was like 7 years old to places like Kenya and China and South America. So I had already sort of connected to folks of the global South. So that sort of chapter one and chapter two really sort of connected, and then sort of led to sort of chapter three. Um, Started working after sort of chapter two and chapter three, working in as a grad student in a number of different places. Spent half of medical school living in the Middle East. I lived in Israel and Lebanon. Worked in the Palestinian territories for almost every weekend. I worked in places like Ethiopia and Kosovo and other places, and that started to concretize my sort of my interest in moving into this space further. And that leads me to the sort of the final chapter, chapter four, which is really like why infectious diseases. It connects more to back to sort of, chapter two, which is really the HIV piece. And
Hmm.
if we, if I'm going to have any particular sort of impact in the global south, connecting to infectious diseases and all of the sort of the public health challenges that lead to infectious diseases, particularly challenges with sanitation and hygiene, problems with sort of immunization campaigns, which is what we're dealing with right now, problems with sort of just medication delivery, workforce development, all these sort of challenges really, can sort of find themselves in this sort of Venn diagram of what infectious diseases sort of is all about.
Hmm.
So, but I particularly wanted to work in infectious diseases in the global south, not so much in the U.S. And so I really kind of focused on tropical medicine and HIV because that was my main focus. So spent part of my fellowship and training with the London School of Hygiene and Tropical Medicine, as well as parts of East Africa, really getting sort of exposure to that particular sort of area of infectious diseases. And then in the US, most of my focus since then has been on HIV and what we now describe as syndemics. So how does HIV connect synergistically to other co-infections or co epidemics like hepatitis C
Hmm.
or like STIs. Syphilis right now being a sort of big one, particularly among women that are of reproductive age, as well as how is it all kind of influenced by the social and political drivers or determinants, which is a lot of what the book is about,
Hmm.
and particularly how does behavioral health, including mental health and substance use, how does that sort of play into all this?
Yeah, I mean, what an amazing journey you've had. Have has there ever been a point in any one of those chapters where you were ready to throw in the towel and say it's too much, right? It's too much, it's too hard. I don't know if I can do it.
Yes, yes, a number of times. Totally. I almost quit med school and residency at least half a dozen times.
Hmm.
Partly for at one point during med school, I left. I was at Boston University, and I dropped out of med school. It's very hard to get in. Less than I think the stat is less than 2% of folks get in. Nowadays, and so I got in, but I had just came back from India working with UNICEF and working with some of the sort of poorest and most vulnerable sort of communities.
Hmm.
And then I'm in a place like Boston with a lot of sort of wealth and privilege, and so that sort of disparity was just I couldn't reconcile that at that
Mm.
sort of stage. So I needed more. So I dropped out, moved back to the global south, moved to Thailand, started working on the book, same book. Took me about 20 years to write. And and then ultimately it's a long story, but ultimately I got accepted to two other universities in the course of the next 6 months. I had totally forgotten that I had actually applied to them. I was actually going to go to the PhD route. And then I said, all right, the universe is calling me back into medicine. So there was that. There was a few times during residency that I just wanted to drop out just because it wasn't what I was learning wasn't aligned with what I knew to be important, right?
Mm.
So I was learning medicine in this context of United States-based, hospital-based medicine, which was not the medicine or the healthcare that I wanted to practice. And so that sort of disconnect, that sort of a cognitive dissonance was a challenge for me. But ultimately, I finished it out because you gotta just stay the course, finish the training, and then I ended up kind of creating my own path where I was able to really kind of focus on what I think matters. So yes, so yes to those. And then I've been in certain other sort of, spaces where, it has been too challenging and I actually did quit. Like for example, I was with Indian Health Service, where in Wyoming with the Wind River
Hmm.
Reservation, providing, direct clinical services to the Northern Arapaho and the Eastern Shoshone. I was also the community health director. And it was tons of good folks out there, so much profound need, but the system was so deeply disjointed and disrupted. It really allowed me to think, how systems come into play and how if the system is so broken, if the system is so dysfunctional, then our time trying to fight from within or whatnot will ultimately just um, lead in sort of us spinning our wheels, right? Will lead
Hmm.
in futility. We have to work within systems that actually allow some traction. And that doesn't have to be in a very wealthy place. It has to happen in a place where there is a realistic opportunity for change and impact. So that was a realization for me, and I'm actually quite glad that I've done it. And actually now with my own organization, we're very close to standing up tribal health programs ourselves, where the tribes will own it, not the government.
Amazing. And what advice would you give to, let's say, other residents or other interns that might be in the same headspace you were in of like, I got to get out? What advice would you give them?
Yeah, well, I love that question. I would say A, stay the course as much as you can. B, phone a friend. Don't do
Hmm.
anything. Don't do anything. Don't jump ship yet. Talk to a mentor, talk to peers, but especially mentors. Hopefully folks have their mentors and they can talk to them. Three, try to medicine and healthcare in today's world allows a lot of creative adaptations of what was once a sort of like, conventional, almost sort of monolithic sort of model. Now there's a lot of opportunities to kind of spin off from the sort of the conventional healthcare space. Could be research, could be public health, could be direct clinical care, could be research, could be teaching, could be a lot of different things.
Hmm.
The business of medicine. So there's a lot of different elements out there. So many different elements. There's tech. There's just so many opportunities out there. So yeah, I mean, just stay the course before then talk to a friend, but don't just jump ship without talking to a mentor or peers, because you put so much effort into getting there. And while a lot of folks, and this is a big problem in medicine in the health in the United States, a lot of med students and residents that come in not necessarily for the what I and others believe are like the most sort of ideal or optimal reasons, right?
Hmm.
They come in a lot of times because they're sort of pushed by their family, a lot of times just because they can, because they're graduating at the top of their class and whatnot. And people just like, oh, you should just be a doctor or, whatever, scientist or an engineer or
Hmm.
something, without actually kind of thinking it through. And particularly folks that go from just undergrad straight to graduate school, we see that happen straight to residency. We see that happen all the time. So, if you could take your gap years or whatnot, if I'm talking to residents versus me talking to undergrads, it's going to be a different conversation.
Sure.
Undergrads or whatnot, or grad students, I would say take some gap years, spend some time, explore the world, see what's really out there.
Hmm.
For a lot of folks, I really strongly recommend taking a sort of like a health policy or public health master's degree, or at least some courses to really understand the macro before you get into the micro. Because
Mm,
when folks are going into their clinical training, whether it's a physician or physician associate, nurse practitioner, physical therapist, etc., a lot of times it's a technical skill. You're going to trade school,
yeah.
right?
Yeah.
And so you're not learning anything about the way that sort of health systems are set up and how you can kind of operate in that. And a lot of times folks do get burned out as a result because they went in thinking, oh, I'm going to do X, Y, and they have, all these kind of aspirations to come save the X or save the Y. And then they find out how challenging that is unless they really understand the systems. So understanding the macro, like and it could be through experience, doesn't have to be through a graduate degree, but one of the two for folks who have not yet gone into medicine or whatever their final graduate degree is,
Hmm.
spend some time really understanding the scope and the context and the outer sort of layers of what you're going to be working in, as opposed to sort of after, because it may not be for you. And I know after I've given this advice, a lot of folks don't end up going into kind of like direct clinical care. They'll end up going into like a PhD or a DRPH or
Hmm.
other sort of connect to the macro. So.
Yeah, I mean, I think it's great advice. Burnout is obviously, I don't know how big it is in the physician community, but I know it's a pretty big deal in the physical therapy community, especially coming out of COVID. Um, so I think that's great advice to just kind of know what you're really passionate about and how the system works and how your passion can interact with the existing systems and how you can make it work for you, I think is really important. I think it's great advice.
It
Uh,
is, and just so a quick response, it
yeah.
is it is pretty it is quite prevalent in
Is
residency.
it?
I actually published on this. Residency burnout, super prevalent. Definitely, but far more prevalent in the clinical specialties that focus more on kind of direct patient care.
Hmm.
So that could be family medicine, that could be emergency medicine tends to be number one,
Mm.
and family medicine and even internal medicine will definitely be at the top. So it's particularly the specialties where there's a lot of kind of administrative burnout. Burnout is based upon three different um, scales, instruments, to essentially grade it. And the essentially the most important one is emotional sort of dissatisfaction, or
Hmm.
I might have there might be a word there that I missed. It's been a while, but that was the most important. Then there was like depersonalization and one other domain that I'm forgetting.
Hmm.
But essentially, thinking through those three domains, the major piece is the disconnect, that the emotional disconnect from what you're actually doing.
Yeah. Yeah. That makes perfect sense. Like when your expectations are not even remotely being met, it's really it's like then you're thinking, well, what am I doing? What's the point? Right?
Yep.
Yeah. Yeah. Great advice. Okay. Now let's get to a little bit more about your book and about what you do. So, like I said, in the book, part of it is looking at pandemic responses through history, plagues to COVID. And you can if expand a little bit more about what your role was during COVID. But based on your research, what are the most striking parallels between how societies dealt with these plagues or pandemics in the past versus now? And have we learned anything from history, or are we still making some of the same mistakes?
Well, great questions. I will start with. Is it okay if I just kind of start with the way that the book is laid out? Because I
Yeah.
think we'll kind of respond to it. So the book is laid out into three different sections. So just to kind of recap the name of the book: Pandemics, Poverty, and Politics, decoding the social and political drivers of pandemics from the third plague to COVID-19. So part of the reason, so first section really is just all about social medicine. Why it matters, what the social determinants of health are, and how that sort of all unfolds. A lot of folks, particularly in healthcare, were inundated with the concept of the social determinants, or the SDOH, but not a lot of people really. can sort of go through all the different layers, including myself. I mean, it really, as I studied the book, I really needed to get into like the social sciences of all the different sort of layers that lead to the social determinants. So kind of peeling back those layers of all those different domains is important. So that's the first sort of section. Second section is looking at every relevant pandemic, and I define pandemic in a particular way. And but outlining every particular pandemic as it's defined from the third plague and the sixth cholera pandemic, which were around the same time, around 1899,
Hmm.
to the present, essentially, which is COVID-19. So we are not out of COVID. I know a lot of people say, "Oh, when COVID happened, we are not out of COVID. We're out of the pandemic of COVID." But that may always come back.
Hmm.
Uh, and so we COVID now is endemic, and it will sort of stick with us. And so anyways, so the second section is looking at all of these pandemics, and I lay out, a number of them, again, starting with those two that I just described, in addition to sort of like the 1918, which was like
Hmm.
sort of the most well-known one, most infamous one, the 1918 Spanish influenza did not actually originate in Spain, originated
Right.
in the States. And as well as, a number of other flu pandemics, the 1957 Asian pandemic, the 1968 Hong Kong flu, as well as the H1N1.
Oh,
Um,
yeah. Yeah.
and then I look at Ebola, I look at HIV, of course, which is still ongoing,
Yes.
and then of course COVID-19. And then I look at the current top infectious disease killers, contemporary infectious disease killers across the globe. And for each one of these, I basically kind of outline the sort of the history, some of the social political determinants, and then I give a reader a rubric or a grading instrument to basically determine whether or not they agree that there are five different points, that they can kind of see sort of across the spectrum of all of these diseases. Okay, and so then the reader, it's self-guided, but ultimately, I hope I write compelling enough arguments that they do believe that at least majority of them were strongly influenced by the social and political drivers or determinants. And then we get to the third section. Okay, now that we've got your attention, what do we do about it? Um, and so um, and so, to your question, it is what we have seen throughout history has been this very consistent sort of thread, which has been, that either governments have not worked in collaborative sort of ways with other government agencies, and there's at least two to three different concrete examples of that, particularly examples of the Chinese not working in collaboration with the WHO and other sort of organizations. There's a lot of reasons for that. I'm not demonizing the Chinese, government at all. But these are just examples of, I believe mistakes at the time, not collaborating when we're dealing with infectious disease outbreaks. They clearly can sort of pass through borders. They don't recognize borders, and so if we have these elements in place, particularly certain policies that essentially discriminate against migrant communities, that essentially lead to more impoverishment or whatnot, and there's more inequities, you're ultimately going to be more of a diffusion of these infectious disease outbreaks that lead from epidemic scale from local outbreaks to
Hmm.
epidemics. And so that's really the sort of the common thread throughout all of these. HIV, Ebola, all of these in sort of in our life has certainly sort of shared some common sort of contributors, and it leads to something, our sort of our sort of ongoing inequities in these systems in the US and sort of globally. These sort of chronic health inequities lead to something that I describe as population stress. And so it's these inequities, it's all of the things that lead to the inequities. It's a lot of the chicken and the egg, right?
Hmm.
But it leads to this sort of pressure cooker of systems or nations that do not have functional infrastructure in place. And part of that's political, part of that's social, then the more gaps that we see, right, leads to those inequities. When we look at poverty, for example, there's absolute versus relative poverty, and I talk about this in the book. So when we're looking at absolute poverty in places like sub-Saharan Africa, most places in sub-Saharan Africa, absolute poverty. across the board categorically poor. There are certain countries like South Africa, which is distinct sort of, African country where we see profound inequities between the rich and the poor. And most of that's white versus black, right?
Hmm.
And so when we see that, we see a significant increase, and that is graded by the Gini coefficient. So we can rank that very clearly and then correlate that with disease outbreaks and whatnot. And so what we find is in places like South Africa, in places like Brazil, with profound inequities. We see criminality increase significantly. We see political activity increasing significantly. During apartheid, when apartheid was started sort of coming undone, the decades that led to that, right? Lots of political unrest led to what I believe was the sort of increase um, spread of HIV. Meanwhile, it was all under the radar. We didn't even know that HIV existed. But
Right.
meanwhile, all this political activity and sort of unrest was sort of unfolding. And so, virulence, basically the spread of viruses and the sort of the sort of the pressure cooker of the barometer of how sort of viruses both infect and cause disease, which is pathogenicity. Um, is accelerated by stress, right? And so if you
Hmm.
take, so that's from an basic immunological principle, where like the herpes virus very commonly will manifest like as a blister, for example, when people are stressed. Stress
Right.
can be sickness, stress can be a lot of things. So I describe that as population stress. So when there's all this inactivity, when there are systems and people not aligned, when people are dealing with food insecurities and all these other pieces that lead to immunocompromise, then ultimately it leads to the perfect conditions for an infectious disease outbreak to become an epidemic, and ultimately from that epidemic to then cross borders into pandemics because that population stress, because it was just a pressure cooker just ready to explode.
Right. Right. And in your experience working with these populations and in different parts of the world, what what, if anything, helps to contain that pressure cooker? Has
Yeah,
is it possible?
it
I guess
is.
is
No,
the
so
question.
it's definitely possible. I mean, parity, equity
Hmm.
leads to equity and equality are not the same, right? So
Correct.
equity is, especially health equity, will lead to basically more sort of even conditions, less disparate conditions, which ultimately to sort of more harmony, better, and again, it's getting back to the social determinants, right? So looking at education, looking at transportation, looking at sort of childcare, looking at all these different elements, looking at our income, of course, looking at food security,
Hmm.
looking at all these different elements that we can sort of measure and rank. If we have more parity, more sort of even distribution of these services, Scandinavia is a perfect example. Scandinavia, yes, smaller countries, a little bit more homogenous countries,
Hmm.
yes, but these are often the sort of like the reference for more equitable sort of conditions and less risk for pandemics taking place. Other examples, that are not exactly as harmonious as the Scandinavian sort of countries, but other countries that have really good public health infrastructure and less inequalities: Singapore, Korea, Japan to some extent.
Hmm.
When it came to the COVID-19 pandemic, a lot of these folks, they like Korea, was one of the countries in the very beginning that had pretty profound incidents of infections, and they jumped on that really quickly. Partly because, and I explain this in the book, partly because they had experience with prior outbreaks and pandemics or public health emergencies of international concern, like the SARS of CoV-1, which was
Hmm.
2001, as well as MERS, for example, Middle Eastern Respiratory Syndrome, which actually got out of the Middle East. Historically, would be sort of described during the Hajj and during basically mass gathering events,
Okay.
particularly in the Middle East and Mecca, Medina mostly, and then it would travel to other countries like Korea. So they already
Hmm.
had so I describe Korea as basically a concrete example of that strong public health infrastructure, not a lot of inequities, but also just a good understanding of good public health
Hmm.
efforts. So yeah.
Yeah, you beat me to it. That was my next question was, could you give some good examples of where there is some sort of medical and health equity? So
Yeah.
you sailed right in before I could even ask the question.
I'm
Um,
on the same page.
yes, yes. Now, as you've discussed, you've been out working with Doctors Without Borders. You've been on the front lines of major disease outbreaks, including Ebola and HIV. You've worked with refugees, asylum seekers, marginalized communities. So, how do working with those populations, how does it shape your understanding of these preventable diseases and why they continue to kill millions of people, even though they are preventable? And we live in a world with lots of wealth and lots of technology. So I think a lot of people think, well, why isn't this solved? So, why isn't it solved?
Sure. Well, I mean, it's. I think there's two questions there. One was the questions I heard. The first question was
Mm-hmm.
being on the front lines of some of these epidemics, pandemics, outbreaks, different definitions to these three pieces. How did that kind of change my thinking? And so I think I've been fortunate enough that I've been able to kind of experience these emergencies through both that sort of frontline perspective, so on the ground, boots on the ground, sort of individual perspective, working with direct patient care, in addition to working with the systems, right, to oversee it. And now I kind of describe, I still see patients as often as I can, but I work more with sort of, systems and communities. And so I kind of treat the system as my patient now, and I often describe the system as quite sick, right? And so requires a lot of convalescence, so a lot
Mm-hmm.
of effort. So I'm spending more time on that because I've sort of acquired a specialty in systems convalescence. It's the first time I've used that.
Uh-huh.
Uh, and but anyways, but having the sort of the connection between the two, being truly on the front lines, being in the foxholes, and not just in the ivory towers and sort
Mm-hmm.
of the academia, just kind of like hearing about it. It made me emotionally connect to it, right? Like it's not abstract to me. This is real. Like I've seen, babies have died in my arms, right? I talk about this in the book. Babies have died in my arms. I've seen sort of the mass destruction of villages. I've seen a lot of things that I wish I could unsee, but the reality is they're there, and so I emotionally connect to them, and that drives me.
Mm-hmm.
It's when I run an organization, Wellness Equity Alliance. We focus a lot on at-risk youth in places like New Mexico. New Mexico, we're working with carceral populations, reentry populations, people that are in jails, and getting them out of there. Down in Southern California, we're working on street medicines, providing direct clinical services to the unsheltered and housed. Many of these folks are migrant workers and sex workers and whatnot. And again, I continue to see these patients, but working again from the macro level, I'm able to connect the two, right? So it's for me, it's not just, I'm not disconnected from these pieces,
Mm-hmm.
right? I'm very much connected. My heart's very much into it. And I'm part Italian, so, heart means a lot to me. Um, so yeah, so that was the first question, I think.
Yeah.
And the second the response to the second question was how do we have effective responses to some of these
Right. Some of these like preventable diseases, we've got wealth and technology. So, why do they continue to kill millions of people around the world?
Sure. So I think, in terms of when we were coming out of the COVID-19 pandemic, a lot of the thought leaders really tried to distill, the sort of the messaging. What did we learn, right? Like what did we get out of this? And the way that I kind of sort of teach or discuss is I learned five different pieces. One was that we cannot look at infectious diseases through one sort of monolithic lens, right? Like it's not just COVID-19, it's not just HIV. It is these cascading impacts. It is these is syndemics, getting back to that word again, or these syndemics that where you have a number of epidemics that are working together, not in an additive fashion, but in a synergistic, multiplicative fashion. So that is really key to that's a key sort of outcome of the pandemic. And a lot of those syndemics again are influenced by the social and political drivers. So if we just try to study and like identify surveillance and response to just the disease, we will fail,
Mhm.
right? We need to basically zoom out and understand the social and political context in which these diseases emerge and try to address those. And those in real time during gray skies, we need to basically set up, mass we called them pods during the COVID-19 pandemic, points of dispensing. Set up mass pods that have community-based organizations working with their so there's a friendly face, there's known sort of, messengers.
People in the community. Yeah.
Yep. And then that's gray skies. During blue skies, we need to be setting up, different sort of, more kind of sustainable communication channels. So I'll get to that in a
Mhm.
second. But basically, so first part, really framing the disease as a syndemic. Number two, understanding the importance of health equity. If we continue to have these inequities, which is what our entire conversation is about, we will continue to see these preventable diseases, literally vaccine preventable diseases scale, which I mean, even become a reality to begin with, right? Like even become outbreaks, which are again were preventable by definition. Number one to number two, ultimately scaling to become epidemics, and then beyond that, transnational borders becoming pandemics. So that's the importance of health equity. Third, that community and multi-sectoral partnership. So it can't just be the doctors, it can't just be the insurance companies or the health plans. You got to have the community-based organizations. You have to have the faith communities. You have to have the special interest groups. You have to have the unions. You have to have these folks that represent and have the faith and trust of these communities and have everybody at the table so you can have that sort of like effective dialogue. And it needs to start at the very beginning. You cannot do this sort of midstream, right? You need to start those conversations at the very beginning and hopefully have that sort of consortium ahead of time. And then finally, the importance of public health emergency response and resilience. It's not enough. So that's what we in public health called FEP, public health emergency preparedness. It's not enough to do these drills in the abstract, watch a webinar or something like that. We
Mhm.
really have to be prepared. We really have to understand how to kind of activate our contingency plans and sort of what to do. So super, super important to get those done. So that's sort of what we learned. In terms of like that's sort of more the strategic sort of outcomes in which we need to sort of focus on. In terms of like the more individual tactical pieces, I break these into sort of six different components. The first is, Karen, is effective leadership, right?
Mhm.
So we have been lacking that for sure, and it's getting worse with the current administration.
Mhm.
So we need to have effective leadership. We need to have somebody who's got the helm, who knows exactly what they're doing, and who's working again with those community and multi-sectoral sort of partners. Now that could be, I make the argument in the book that the U.S. Surgeon General has a lot more teeth. We don't often hear about that, right? Like we hear a Surgeon General with cigarette warnings and whatnot,
Right.
but the
Right.
Surgeon Generals really, under a more responsible, sort of administration, Surgeon Generals really have the capacity to get a lot done because they have the U.S. public health personnel that are working underneath them. So there's a lot of traction, a lot of teeth that they could potentially have. CDC. A lot of people say, "Oh, why can't CDC do it?" CDC is an advisory agency. CDC doesn't not actually have a lot of operational capacity, and they're removing even more any sort of operational capacity that they did have. So
Mhm.
effective leadership. Clear and consistent messaging. Number two, clear and consistent messaging. It needs to start from the top in the very beginning, and then you need to communicate effectively with your state leaders, your community leaders, and there needs to be just basically like a chain of command that goes through these different channels. We need to set up the consortiums ahead of time. There are some sort of scaffolding that does exist right now, and I talk about this in the book. I mean, we get very technical, but there are agencies, so we're not starting from scratch that we could really set up for success. But there needs to be coordinating sort of elements to these agencies so that they know that they are working with one another.
Hmm.
Um, we have to have workforce development. We have to make sure that we are focusing on certain workforce that where we are sort of struggling with inequities, particularly in terms of representation of those clients. A
Right.
big one is behavioral health. Behavioral health, we define that as psychiatry, addiction medicine or substance use disorder treatment and prevention, and behavioral health counseling. There are profoundly underrepresentation of these public health or healthcare professionals in general, and definitely a profoundly anemic representation of Black and Brown communities, in the behavioral health workforce. So we have to think differently. So at Wellness Equity Alliance, we're working a lot with community health workers or certified peer support workers that do look and talk like the communities in which we need to get to. People that have lived experience, but that have opportunities to get some certifications or trainings. So it's clear that we do that. Um, we already talked about this, but having clear and consistent messaging.
Yeah,
You have to be the more that I often sort of make the example of if a patient is in the ER, really more appropriately the ED, and you've got two docs that are openly arguing about the diagnosis and the treatment, that person's confidence in that sort of system or that institution is going to go downhill like
totally.
precipitously. So you got to have clear and consistent messaging. You have to all be on the same page. And here's the good news. There's science, right? Science has existed for centuries, right? We have
Right.
all this evidence, evidence-based medicine. So we shouldn't be making this stuff up. We should just be following the science. We're
Right.
not doing that enough. The last two things, data-driven. We have to be data-driven as much as possible at intervention. So that evidence-based medicine model has to, again, kind of follow the data. And then finally, the models need to be innovative. We cannot continue to work on these clinical models. The brick and mortar, the white coats, and all that. That doesn't work for at least one third, if not more, of the United States and well beyond the U.S. It just does not. There's good evidence for that. A lot of folks, especially for prevention, they don't want to be sick. So for folks, I work a lot in HIV. So for folks that are at risk of HIV, particularly, the healthiest, the ones that are out there having a good time. They don't want to come in to get PrEP or to get sort of antibiotics or whatnot. They just want
Hmm.
to do their thing. So
Hmm.
let's get it out there. Let's make it as easy as possible. Same thing with the unsheltered unhoused. They don't want to be bothered. They've chosen a different path. So meet them where they're at. So that's really a lot of what we do at Wellness Equity Alliance is we identify innovative clinical service delivery models that really meet folks where they're at in a really meaningful way.
Yeah, it's a lot of moving parts, but it sounds like there's some structure there to get it done. It just and that takes us to the next thing I want to talk about, and that's sort of the political decision making and public health, where, you know, maybe things start to break down a little bit, right? So you've got different viewpoints. You've got it in within the United States. We're both in the US, within the United States, and across the world. So, what are some key political factors that can determine whether a society protects its most vulnerable members? And we could say during a health crisis and outside of a health crisis, because it should be protecting those most vulnerable all the time. So, what how does political decision making and public health all play a role in everything that we've talked about so far?
Yeah. Well, I love all your questions, Karen. We could talk for a while. So the way that you just said that you kind of delineated between during crisis, during not, we talk in like emergency management, we'll say blue skies versus gray skies. So blue
Okay.
skies during normal, whatever normal is, days, non-emergent sort of days, and then gray skies as being sort of during emergent days. So yeah, I mean, great questions. It's ultimately how do we have the how do we basically coordinate enough political buy-in to ensure that there is focus on kind of closing the gap on some of these inequities. I often talk about the systems in the United States, the healthcare system in the United States, and public health. So just to be clear, healthcare, public health, different, right? A lot of different systems in the U.S. that they should, now these two, they're different. They should interact. They
Hmm.
don't. They don't as well as they should. There are certain examples, there are certain concrete examples where they do. They do interact a little bit more effectively. But as a general rule, and my organization worked during the pandemic. We administered over 2 million COVID vaccines. So
Wow.
we worked with in over 10 state health departments. And we have good examples. I'm not going to get into that here, but we have good examples. We have not so great examples of where there was a little bit more integration between healthcare and public health. So it's all these cracks in the pavement. It's all these cracks in the system that are a significant challenge, and a lot of that is political. So when we look at basically where we did well in terms of sort of vaccine penetrance, when we look at mortality, when we look at a lot of these other kind of correlated sort of social determinants, we see a lot greater correlation with red states in terms of sort of poor outcomes than we do with blue states. Now, there's been increasing evidence that that's not actually true. But in terms of the evidence that I have seen, it absolutely is true. In terms of certainly in terms of better sort of vaccination coverage, absolutely much better sort of penetrance or sort of coverage in those blue states.
Hmm.
And in terms of those messaging, a lot of those things that I was just talking about, the governance, the leadership in many of those states undermine public health. And that is such a profound problem because and that it's getting worse right now. Now as before it was state because my sort of message, to your viewers was during 2021 to 2024 I and many of others were feeling relatively more confident than we were, prior to the pandemic. Like, okay, the silver lining is COVID-19. It was finally it was an equalizer of risk, right? When we're dealing with a lot of other infectious diseases, particularly pandemics, a lot of folks in the global north, we describe that as, US, mostly OECD countries, mostly developed nations. So that's the
Hmm.
United States, that's Europe, that's parts of East Asia, et cetera. They mostly thought that they were, not at risk. For many of these. So for many of these diseases, your malaria, your TB, your diarrheal diseases, etc.
Hmm.
But HIV to some extent crossed borders and made people feel as if that they were at risk. People definitely do not feel as if they're at as much risk nowadays because we have such good, effective treatment and
Right.
prevention programs. COVID-19 was that one that really just crossed all the sort of borders, all the sort of transformed all different sort of social uh, domains.
Hmm.
And many of us, while certainly the most historically marginalized were the most at risk, that's the whole point of the book. Certainly, other people in the most sort of privileged or the most sort of disconnected from sort of poverty or other social drivers were at least one degree of separation away from having some pretty profound experience with.
Right.
So, so many of us thought that, okay, equalizer of risk, the perception of sort of risk would have sort of transformed or changed. Unfortunately, now with the current presidential administration, with the Secretary of the Department of Health and Human Services, I often describe as the chief pseudoscience officer. They're doing such a disservice. They are literally disrupting all of the work that we have put together, not just the last 4 to 5 years. We're talking decades. They're trying to dismantle or disrupt all of these sort of systems in place. And it's super unfortunate because there's so many people. It's not even a village. It takes mass tsunamis of villages coming together and really just like putting their life, their careers into this thing and building out these systems and the research and everything that's been implemented so we understand what we should be doing.
Hmm.
Unfortunately, now the political sort of, those with political agency are removing all of that. And it's super unfortunate because public health and I say this all the time. I say this in the book. It's part of the reason why I write the book. Public health needs to be depoliticized. There is no reason why public health should be politicized. There's no
Hmm.
reason. It is there. It is literally there for the common good. It is like any other sort of common agency, like law enforcement, like fire service, etc. You may have politically distinct perspectives of how law enforcement and fire service or whatnot should operate, ambulances, hospital systems. But the
Hmm.
reality is, I think most people would agree that they should exist in some capacity. Same public health is the same thing.
Oh, of course.
There,
Yeah.
it is there to protect. It is there to protect our public, our populations. And if we do not invest in it, even if you feel like if your politics say, I don't really care about, the homeless, or I don't really care about migrant communities, okay, fine. That's your political belief. You're totally entitled to that. The problem is once all of these social and political sort of collisions come together, it will ultimately impact the system in which you are consuming care. And that's exactly what
Yep.
happened with the COVID-19 pandemic. That folks that were having, their wives, uncles, whatever, were having heart attacks or other normal blue sky stuff, they couldn't get into a hospital. They could not get into an ICU, and as a result, they died. So
Right.
there's COVID-19 was not my father included. COVID-19 was not the reason, was not on your death certificate, but it was ultimately the social and political sort of driver of a lot of that morbidity and mortality.
Hmm.
And if we don't focus on it now, and we don't invest in it further, and we have these further recessions like we're currently having, it will get significantly worse. And so what we're seeing right now with this political administration, even though again, red states, blue states, it shouldn't matter. It's for everybody. It is ultimately there's people will find that those inequities are going to flare up even further. And so the next infectious disease outbreak is going to even be that much worse. And that's unfortunate. But I still have hope. I still have hope. We were talking about this before. I still have hope.
Yeah.
I do believe that the pendulum will swing back. And I think that the more disruption, which is clearly intentional at this point, basically breaking up the CDC, advisory council on immunization practices, basically the subject matter experts, uh,
Hmm.
in the room on immunizations and just healthcare in general. Breaking that up and all these other sort of things that are happening. Removing certain vulnerable populations from the formularies of health plans and whatnot. The point is to disrupt as much as possible. It's clearly the point. There is no alternative explanation. But our hope in healthcare and science is that the science will ultimately overcome. And public health, which is driven by science, will ultimately overcome. So we believe that the pendulum will swing back. And as people, unfortunately, there will be more people that get hurt in the immediate future. But as that continues to happen, people will continue, blue and red states will start to voice their
Hmm.
concerns. And so all of the impacts on Medicaid and all the sort of like the safety nets and the infrastructures that we have for this country, the
Hmm.
pendulum will swing back. And I do believe that we will be in a better place in the future. I don't know when that is, but at some point in the future. And hopefully, at the very least, people will get out there and vote and understand how their vote leads to not just sort of political decisions that are looking at sort of tax breaks or whatnot. They absolutely will impact their access to healthcare and public health.
Yeah, absolutely. And I always think of, those folks who live in more rural America, which, by the way, I don't have to tell you this, it's a lot of America.
Yep.
So, what happens when those public health initiatives and those rural hospitals start to disappear? So, to your point, you may think, well, this isn't going to affect me.
Yep.
Well, it probably will when you have to drive 200 miles to go to a hospital and maybe you're not going to make it.
100%. So that is we talk about this often. Rural health is one of our strategic priorities.
Yeah.
And that is the reality, Karen. You just hit the nail on the head. Like that is when it comes to rural, which is a lot of the 47's base. Uh,
Hmm.
the reality is they felt they had, certain opinions about, the world and whatnot, and that's fine. But from a healthcare standpoint, and that's all I can really talk about is from a healthcare public health standpoint, when you are making those political decisions, you are voting against yourself in terms of access. So what's happening right now, rural critical access hospitals, this was an initiative that had been pushed by HRSA and SAMHSA and a number of other federal alphabet agencies. Those are all those are all getting disrupted right now. So folks that could have had access to some life-saving measures, that's all going away.
Hmm.
And so people are reliant on getting to hospitals, to your point, that are literally 200 to. I used to work on the Wind River Reservation, where the closest local community hospital was at least 80 miles away. The closest academic medical center was about 300 miles away in either
Oof.
Denver or Salt Lake City.
Right.
So if you really needed a life-saving sort of, you could get airlifted, but think about the costs of that, right? So these
Right.
folks that are in these rural sort of areas are absolutely getting, these clinical services, which could have been advanced, and my organization does do that. Now it's kind of we're going several steps back. Now, again, leaving with the positive news, with the good news, I think organizations like Wellness Equity Alliance and other organizations that are big thinkers, they will
Hmm.
think about how they can do more and how the public-private partnership can work together more efficiently. So because the people will continue to get sick and they're going to get sicker the more that we roll back this infrastructure.
Hmm.
But with organizations like ours, we're really thinking through innovation, working again with the public sort of infrastructure. We could kind of come in there and try to provide as much sort of safeguards as possible. But that's a lot of work.
It's a lot of work, and it, to your point, it's takes a lot of innovation. It takes a lot of manpower, um, and it takes a lot of coordination, which a lot of that might have to a certain extent already been in place, but now because it's being disrupted so much, it's for me, it's the unknown, because we don't quite know what's going to happen if more things are rolled back and dismantled. And so I think that's the part that's a little unnerving. But I like your point that, listen, the pendulum's way, way over here. It's got to swing back. And perhaps with organizations like yours and maybe other private public partnerships, when that pendulum swings back, it might be even better than what we had previous.
We have to hope.
Yeah.
Yes.
Yeah. So I'm still hopeful too. I'm still hopeful. So aside from this, maybe more coordination between a public and private partnerships, what's the path forward? Where do we go?
Well, I mean, where we go is just getting back to kind of, what we were describing earlier was we have to focus on those six or seven different buckets. One is we need more effective leadership. We're kind of right now
We're a little drained.
we're in a funk in terms of our current leadership. So we gotta work on that. Again,
Mhm.
pendulum as the result of sort of this sort of anemic leadership right now. I believe that more effective leaders will come out, and we'll have. I think it's essentially creating sort of like a pipeline for more.
Mhm. Mhm.
So that's a key one. We have to coordinate those messaging or those consortiums between the relevant stakeholders. That has to happen now. Now, again, given all the challenges, I think there's going to be a lot of formidable barriers in the next 3 years. Hopefully, something will change, but we'll see. But yes, we need to have the consortiums of the sort of the communities that reflect again mostly importantly the most historically marginalized. So that's the homeless. Those are the sort of
Mhm.
immigrants. Those are the LGBTQIA plus. Those are a number of other kind of special interest groups. So we need to have effective community leadership of them and make sure that they are connected again with that effective leadership from the federal to the state to the city county level. There are agencies or organizations out there that is their mandate, that is their job. Organizations like NACCHO, National Association of City County Health Officials, ASTO, the agency for state and health officers, or Association of State and Health Officers, as well as another number of other organizations that bring people together. So that is their mandate. They have funding to be coalitions or consortiums. So that's a key piece so that when we are in gray skies, we can just activate it.
Mm.
Standardized infection prevention control models. Those our models need to be standardized. We cannot have diverging opinions when it comes to like masks and vaccinations and whatnot. We're not making this stuff up, right? There's tons of evidence to support this, overwhelming evidence to support all these things. If you have concerns, don't go to your echo chamber. Don't go to your social media. Don't go to
Oh
Google.
God, don't ask Twitter or X or whatever it is. Yeah.
Don't go to Google. Like talk to your primary care providers. If you do not have one, try to reach out to your local FQHC. Talk to your public health professionals. Those talk to the experts. Don't just make this stuff up and then go into your echo chamber because this is what's constantly happening, and that
Mm-hmm.
gets Clorox and all this other kind of like nonsense.
Yeah.
Um, the interventions that we have, they have to be data driven. So they have to be evidence based. We should not be implementing anything that does not have that sort of capacity.
Right.
And we did not just not at baseline, but also continue to have M&E monitoring and evaluation to see that our implementations actually have traction. Workforce development, we cannot continue to think that the solution is creating more doctors or medical doctors. It is not this. That is one of many solutions, and there are a lot of reasons why we don't have enough medical doctors, and that's a long explanation. But my point is, we need more. We need more alternative workforce. So to getting back to the rural piece, our organization has experimented with community paramedicine, for example. So community paramedicine, you completely divert the whole 2 to 400 mile trek to like a local hospital,
Mm-hmm.
basically having the paramedics work with the physician through telemedicine or something like that, and then having the sort of the standardized standing orders rather for the community paramedics to be
Mm-hmm.
working directly with those folks, and then connecting them to a primary care provider, either locally or kind of through telehealth or something like that.
Mm-hmm.
So community paramedicine, definitely a really interesting sort of workforce that we could sort of cultivate. Street medicine, innovative, working with it's a lot of community health workers. It's more it's community health workers that are trained in behavioral health. Absolutely like essential that we expand that workforce. Behavioral health, there's not enough of
Mm-hmm.
them, and it's not just not enough of them. Most of them don't look like the communities in which I am currently serving, and that is a natural disservice for these folks.
Mm-hmm.
And then, finally, innovation in the clinical service delivery models. We can't continue to think that the same models are going to work. The brick and mortar just doesn't work for a lot of people. A lot of
Yep.
people don't want to come into clinics. A lot of people don't want to make an appointment. A lot of people don't want to come into hospitals. They want to just have it as easy and low barrier as possible. So we have to think about as much innovation as we possibly can. Telehealth is one example, community paramedicine, street medicine. There's a
Mm-hmm.
lot of different modalities out there that we could experiment with.
Yeah. Amazing. All right. So, as we start to wrap things up, where can people find more about you, more about the book, and more about your organization?
Sure. Thanks for asking. So the book could be found so it's published by Johns Hopkins University Press. So it could be, you could just Google Johns Hopkins or Pandemics, Poverty, Politics, and you can order it there. Number two, Amazon is always your kind of default. So
Mm-hmm.
get it on Amazon, and then it's on Barnes and Noble as well. In future state, if we get enough requests, maybe it'll even get out to your local, airport bookstore, kind of local brick and mortar bookstores if
Yeah.
those sort of exist. I know they do, but like your kind of smaller sort of mom and pop bookstores or whatnot. And then in terms of just kind of reaching out, wellnessequityalliance.com, wellnessequityalliance.com. We're uh, feel free to kind of noodle around there. We
Mhm.
have, if you are in New Mexico or California and need help, reach out. If you feel like there's any interest in kind of partnering on certain things, research, etc., feel free to reach out. If not me, somebody else will respond. And then finally, I have my own website, tylerbevансmd.com, so folks can reach out there and send me a message.
Perfect. And for all of you listening, if you have not already been taking notes, whatever platform you're listening on right now, you can just scroll down to the show notes and we'll have direct links to all of those sites that Dr. Evans just spoke about. So before I let you go, one more question. It's one I ask everyone, knowing where you are now in your life and career. What advice would you give to your younger self, your 20-year-old self?
Sure. So I mean, I would get back to that conversation that we were having before. Like for the students, for the residents, if if you are if you have a if you have sort of creative potential and you're going into area that sort of stifles your innovation, and but something continues to move you through it, don't stop. Continue the course. Talk to your mentors. Talk to your peers. You might need to take a knee. You might need to just take a few years and do something really unconventional and really cool and have more lived experience, and then come back to it. But that's what I would have said, and it would have probably saved me some money and some time. But for me, the journey was this sort of tangential or sort of circumferential journey
Hmm.
actually ended up to provide me with a lot of good insight. So
Yeah.
I'm not displeased that I took a longer path, but yeah, I would have told myself to definitely stay the course, don't stop, and continue to pursue your dreams.
Yeah. Great advice. Well, Dr. Evans, thank you so much for taking the time out, coming on the podcast. Great information. I'm so happy to have had you on. So thanks so much.
Yeah, pleasure to be here.
And everyone, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.